All right. That was terrific talk and equally terrific discussion. Our next speaker is Nima Allen from neurosurgery at UCSF, a terrific surgeon who will be speaking about craniocervical fusion, indications, and optimizing outcomes.
Does it work? Thank you so much, Kyle, Lee, Lionel, for having me back here. Let's see if this works, Keith. Gave this talk last year, which I thought it was well received, at least anecdotally, from residents and fellows, based on the fact that it was case-based discussion. So I try to focus on the cases and discuss the indications. And is it going to work, you think? Should work. There it is. Okay. Perfect. So I'll show 4 cases. The first 3 cases, one by one, I will focus on the occiput instrumentation, then C1 and C2, and the 4th one is kind of like a bonus case I like to show. These are my disclosures. I'm a consultant for these companies. When do you go to occiput? The answer is simple, is that when you have to cross the atlanto-occipital joint. The most common reason is traumatic, but there's many other reasons that atlanto-occipital joint might be affected. But another reason to go to occiput is that for some reason you cannot instrument C1. And ideally it's not because you can't technically, but it's not amenable to instrumentation, such as there's assimilated, there's erosive changes, or there are vascular anomalies, which I'll show that are that make it unsafe. This is a case that I finished my talk from last year. This is a 67-year-old. I was asking the audience, what should I do? I did what the audience said, and I agreed with it. So 67-year-old with rheumatoid myelopathy, multiple comorbidities. This is the MRI, CT. You can see that the atlantodental interval is increased, starting to have some basilar invagination. Cord is kinked a little bit. And on the parasagittal view, I was showing this, and this is a good example of where the C1 is really hard to instrument. On the left side of the screen, there is some remnant of it that you can engage the C1 lateral mass, but it's on the right side, it's basically eroded. You can't instrument it. So as the audience pulled, we went to the occiput, and I will show the results at the end. But the other thing I was going to mention is I look at also the C3, C4 erosion here, which was instrumental in determining what the lower instrumented level was. So for the occiput instrumentation, just some basics. You want to expose so you can see the external occipital protuberance. You don't need to see all of it, but that is where your superior and inferior nuchal line is defined. This is where you want to place your plate. I use the plate itself to kind of check for how lateral I need to go, because it feels like you can keep going lateral and lateral. You just line it up with your C1 and C2 screw, and you want to get your instrumentation in the midline keel where the bone is thicker and be bicortical, as I'm showing here. Try to get through it and get the best purchase possible. I'm not going to get into the details of how to do it, but a couple of things that I think is worth mentioning. What do you do if you get CSF when you tap the occiput? You place your screw. What do you do when you get venous bleeding? You do the same. You place the screw. You really want to get a bicortical purchase. This is that case 6 months post-op. You have to pay great attention that if you're potentially going to occiput, your head position has to be perfect. I could not get any C1 instrumentation. I put C2 par screw on one side and then C3 and C4, very long lateral mass screws. And at 1 year, I get an MRI and CT. We should be coming up soon to see if that pannus has improved. Alternative to occiput instrumentation is putting a condylar screw. There are a lot of papers about how to anatomically place it, but there's a lot of variability in the hypoglossal canal. If you really want to do it, I would use a navigation. I've yet to do it. I think it's really an option if for some reason you have a Chiari decompression, suboccipital craniectomy from a stroke or something, that you can't place a plate in the occiput. Or you can do non-segmental, so you essentially go transarticular from C1 to occiput. Okay, case number 2. This is a patient with a history of lymphoma, presenting with neck pain, no signs or symptoms of myelopathy. Patient is intact, but neck pain. So you can see that the tumor, again, this is a lymphoma patient, tumor is involving almost the entire C2, maybe a 1/3, about half of C3. So they call me, or they call our residents, they saying that the patient has lymphoma and they're going to do a biopsy before they send the patient over because they didn't have a neurosurgeon. So this was a CT at the time. So mid-sagittal view, so you can't see the C3 involvement, but C3 is involved. But you can see essentially C2, almost all of it is eaten by the tumor. Atlanto dental interval is normal. They do a biopsy, and then the patient arrives with severe neck pain, and this is a CT. So the patient tells me that when they were doing a biopsy, they felt the pop, severe neck pain. They put him in the collar, sent him over. So we repeated the CT to see what happened. It looks like they've fractured the odontoid. It's actually not an odontoid fracture. It is a pars fracture. This actually patient has a hangman's fracture. So you can see the bilateral pars are basically affected. And the resultant spondylolisthesis, the non-eponym name for hangman's fracture is traumatic spondylolisthesis of the axis. This is what this is. Normally, for hangman's fracture, I think C2-3 ACDF would be the answer. However, with the C2 body totally involved, half a C3 body involved, I did not want to go anterior. The goal here was essentially stabilize that fracture. So we're going to talk about the C1 and the special anatomy of C1, starting with vertebral artery. I think the most important cut that you want to look at for C1 instrumentation is this parasagittal view, where you want to see a flow void above the posterior arch of C1, and you want to see this C2 nerve below it. You could see the vertebral artery, or I should say you could see a vessel below the posterior arch of C1, which could be a persistent first intersegmental artery, extracranial origin of pica, fenestration vertebral artery. Bottom line is that you have an artery where your instrumentation is going to go. You can't instrument the C1 for that reason. We'll talk about some alternatives here, but this is a patient I saw just on Monday. He's not a surgical candidate regardless, but you see that artery sitting right there. This is, I think, a fenestrated vertebral artery. Those differences are probably academic. This patient is not getting a C1 screw if he was a candidate. So it's uncommon, but you will see it if you keep looking, and you got to avoid it. This was one of the things that I thought the resident fellows liked, so I'm going to repeat it. I feel like everybody's an expert here, but I will go into details. Like, how do you find a C1 lateral mass, which I think it seems to be kind of what makes instrumentation as C1 intimidating. What I do is essentially find the medial border of C2 pars, and then literally translate north, and that gives me the medial border of C1 lateral mass. Once that medial border is defined, I slowly work my way lateral, so I don't muck around trying to dissect in random locations. So that gives me an idea. This is my goalpost. I go straight up, that gives me a medial border, and I start dissecting it lateral. This is a video from a Seattle Science Foundation where we try to do this. It's kind of hard to see, but this is what we're trying to show here, that you're feeling the medial border of C2 pars, translate north. This is the lateral mass, medial border of it, and you can work your way lateral. Where do you find a nerve? Generally speaking, it's the midpoint of your lateral mass. It is important, if you're taking it, it's very important where you take it. My thought is that take it where you can see it, and if you're past the DRG, you need to keep working more proximal to make sure you're not going to give the patient neuralgia. If you see CSF, I don't think it needs a primary closure. You can stop it and then make sure that the patient's head of the bed is elevated. I think if you pay attention to where you take it, I have numbness almost in every patient because I take nerve in everybody, and I tell them in advance I have yet to have neuralgia. You're not done yet. Once you put your C1 screw, you want to decorticate the C1-2 joint. That's another thing that I feel like there's some mystery about where that C1-2 joint is. If you just follow your top of C2 pars with maybe a Penfield 4, you just drop right into the joint. Sometimes I put a burr in, but usually I just use a curette, decorticate it, and put some allograft in. This is that patient. Video's a little bit too fast. Sorry, I'll play it one more time. But the fracture is realigned, and they actually did quite well. All right. Alternatives to C1 lateral mass. All these different names are essentially saying that your instrumentation is going to involve the posterior arch somehow. I think the best one that conceptually makes sense to me is what Dr. Chapman from Seattle, from Swedish, published, the posterior arch lateral mass, where you essentially have your purchase through the posterior arch and some of the lateral mass in the same trajectory towards the tubercle. If you're going to do that, this anatomy becomes important, particularly osteus. You want to make sure that you are not fooled by this anomaly and not go through the vertebral artery. You could instrument the posterior arch itself. Then you have to make sure that the posterior arch is complete. Okay, third case, 77-year-old also cervical myelopathy. This is a odontoid pannus. Patient does not have a history of rheumatoid, but does have this odontoid pannus. Some cord compression there, very mild. Again, I look to see it, make sure that the C1 is amenable to instrumentation. I see the flow void above the posterior arch on both sides. This case is about the C2 instrumentation, so I'm specifically looking here to see if the pedicle is accessible, and it is on both sides. So my plan would be here to do a C1, C2 posterior instrumentation with a C1 lateral mass and C2 pedicle. This is a flex-X, it doesn't move. When you're going for the for the C2 pedicle, you want to make sure that you don't have a high riding vertebral artery. These are a couple of examples of where you can't place a C2 pedicle. But C2 pedicle screw is better than C2 laminar or pars, and segmental instrumentation is better than non-segmental. So that's comparing it to a C1-2 transarticular, where you also have the risk of getting the or injuring the vertebral artery. Okay, where is the vertebral artery when you're putting your C2 pedicle screw? The vertebral artery is going to be high. It's going to be low and lateral. So let me show you an example here. So if you are aiming the screw too low, that's one way you will get the breach of the transverse foramen and hence the vertebral artery. Or if you're aiming too lateral, that's another way you can get it. So if you can aim high and medial, you should be able to instrument the vertebral artery, assuming that you've insulated the anatomy and the pedicle is accessible. I call this kind of a reverse in-out-in. You know, the in-out-in and thoracic spine, you go out, inside, and back in. Here, you essentially go into the pedicle. If you want to cheat a little bit more medial because you're not sure where the vertebral artery is, you have a slight breach into the canal. The canal is very wide here. You're nowhere near the spinal cord. And then you go back into the vertebral body. The starting point, if you're freehanding it, is like right below that drop from the pars. Again, you aim medial and high. This is like the step-by-step of the technique. Okay, the different things you'll encounter when you instrument the C2 pedicle. If you have a slow venous bleed as you incrementally increasing the depth of your screw, you're in the correct trajectory because you're getting the venous blood from the cancellous channel of the pedicle. If you get CSF, you're too medial, you need to redirect. If you get brisk venous bleeding and not a slow venous bleeding, you are about to hit the vert. Haven't hit the vert yet, but you're about to. You're in the perivertebral venous plexus. And obviously, if you hit brisk arterial bleeding, you have hit the vert, you undersize the screw, I would say you have to get an angio to make sure that you don't have a dissection that's going to propagate. So in this patient, we did a C1, C2. This is 1 year post-op. And then I have an MRI that shows the pannus has regressed. The kinking of the spinal cord has improved. Myelopathy symptoms have improved. Okay, we have 4 minutes for case 4. Okay, my bonus case. 62-year-old, 4 months of myelopathy, essentially, a few medical comorbidities, a very odd appearance of a C2 pannus. Went through a bunch of workup. There was no metastatic or infectious causes. Gets admitted to ICU, medical management. He can't stand because of myelopathy. Gets a standing X-ray. So now here I'm studying the bony anatomy before I go to the video here. Studying the bony anatomy. I don't see anything unusual about the bony anatomy. So I think C1 is amenable to instrumentation. C2 pedicle is amenable to instrumentation. The idea here is to essentially do a C1 to posterior fixation and let the pannus regress. However, the pannus does not seem to be a regular pannus. As you see in this axial view, it seems to really displace the cord to the right side to the point that I contacted radiology folks, and then I was worried that if this is an intradural component or something, like you would see it in thoracic discs sometimes. So the plan was, we'll do instrumentation. I was going to do a decompression and do an ultrasound in order to see. So pause for a second. So I've basically put my instrumentation here. I've cannulated the C1. I'm not putting a screw in yet because I'm trying to see what's going on with the cord and this pannus. And this is the axial view. You see it's displacing the cord to the side. This is a sagittal view. Same concept, is really displacing the cord to the side. Loss of some pulsatility to the cord. So basically I decided to open the dura, and the cord was literally displaced to the side, so the pannus was like staring me in the face. So I used an ultrasonic aspirator to debulk that pannus, make it kind of a more manageable size. You can see the nerve roots around the pannus. You could also see that on ultrasound. I was pulsating, cutting it sharply, still trying to debulk it. See if that. And you can see that degen material comes out. We send that for biopsy, just erosive inflammatory changes. So here I'm getting coagulation, hemostasis with bipolar electrocautery. Gently retracting the cord. And you can see the cord is no longer displaced. I can move it back into more neutral position. Gently retracting or repositioning the spinal cord. And there is no video of this part, but essentially, if you have a spinal cord herniation and thoracic spine, you can do this sling. So I basically put a barrier there with a dural substitute, and then we close watertight fashion, and then put a lumbar drain in. And this is the instrumentation. And the patient did really well. He lives in the Philippines now. Did a video visit with him. All right, perfect timing. That's it.
Great talk, Nima. And I think, that's a awesome video. I think I've seen it before, and great technique. For the residents and fellows, I think the pannus for rheumatoid does go away if you stabilize it, if you wait for a year. In that case, a lot of compression, you took it out. That's excellent.
I would not, okay, I'm glad you brought it up.
Yeah.
Because we were talking to the residents, I would not just willy-nilly open a dura trying to take out this. In this particular case, I just thought that it was intradural component.
Right, it's eccentric,
and it was accessible to me.
Right.
So it's almost as if I could do like a free, like endonasal.
Yeah. But my point is that if it's the central, you can't get to it from the back.
Yep.
Most times, if it's truly rheumatoid pannus, you stabilize it, you come back 6 months, a year, re-image it, the pannus is gone because you stabilized it.
So that pannus that I showed with a C1-2, that
right.
1 year out, it went away.
Right.
Yep.
Great talk. Questions?
Yes, Dr. T. Yep.
And what you've shown, but question is, how do you position the occiput when somebody's got a fairly high T1 slope or some thoracic kyphosis or a large SVA? And when you're fusing them, do you fuse them in relative extension so they're looking forward, slightly flexed?
Yeah.
Because if they have symptomatology from the lower levels and you correct that, once you've locked their occiput in, they'll be looking up in the sky. So where do you choose to put their head? And how do you measure that intraop?
I showed a patient to Lee the other day. Somebody did the occiput to T2, and this patient was like ended up being like this, couldn't open the mouth. It was totally fused. So once it gets fused, you're stuck. But to answer your question, Dr. Tay, I would say I would plan for having a neutral neck position for the operation that I'm doing, and decide if the patient if there's a plan to correct the cervical thoracic junction in the near future, I would probably accommodate for that in a more flexed position in advance. But if I don't have that plan and it's not in the near future, I think I'd rather have the patient in a neutral position, so not to create that problem that you're describing. Horizontal, sorry. And my measurement is intraop. I look at the CBVA, look at where their eyes are looking, look where the chin is, and get a neutral, slightly flex, very slight. I think they do kind of settle in as they fuse, so they could keep looking down. As I was saying, talking about this patient, the guy couldn't like open his mouth. I don't know if that answers your question. Oh, is it like a trial? Yeah. Okay, good. Yeah, sure.
For accessing C1, like C1, C2, I routinely take the C2 nerve root. And,
Me too.
And you're a neurosurgeon, so maybe you're better looking at vessels on MRI, but I get a CT angio with a 3D recon because I'm worried about anomalies like a persistent arch or something like that. So what studies do you get? How do you look at it?
Yeah, I don't think that's unreasonable at all. What I look at, my go-to is that if I see fluid below arch of C1, 100% CTA, and most likely I'm not instrumenting C1. But if I don't see a fluid below arch of C1, I'm confident to use that MRI and not be worried about like persistent first intersegmental things. Yeah.
Nima, along those lines, I mean, that was an amazing review of the relevant anatomy, particularly to instrumentation placement. I was wondering if you could talk about the pros and cons in your view of using navigation to kind of help you get around some of that, those challenges.
I'm glad to mention it. So I would say for navigation, I use a Mayfield. I feel like with Mayfield, there's always a little bit of give, and it always makes me worried that I might be a little off. So I don't use navigation. However, I do think you should not leave the OR without an intra-op CT or O-arm to confirm your screw placement. And I try to tell the residents not to rely on navigation for C1, C2 specifically. That's my kind of biased view. Try to be as use the anatomy as much as possible, because I feel like if you dissect it properly, as I was kind of alluding, you can actually, it's one of the few places in the spine you can literally see where you're putting your screw in, almost not the entire length, but you can really see where you're starting and where you're aiming at. So I don't like to use navigation, but I do intra-op CT before I leave the OR. Perfect.
Nice
Thank
work.
you.
Yeah.
Thanks, Nima.